Good afternoon. Thank you for joining us today for Making the Most of Mealtime, Eating, Swallowing, and Dignified Dining for Individuals with Dementia and IDD. My name is Krista Wilk. I'm a research assistant at the Benjamin Rose Institute on Aging and the Dementia Inclusive Community Project Coordinator for the Administration for Community Living Alzheimer's Disease Programs Initiative project titled Expansion of Dementia-Capable Communities Within Urban and Rural Settings in Ohio Using Evidence-Based and Informed Programming. This session today is being offered as part of this Administration for Community Living project. Today's webinar will be recorded. During the webinar, you may submit a question at any time using the Q&A button at the bottom of your screen. We have staff monitoring the questions and the chat to convey your questions to our presenter and to answer any technical questions you may have. You can turn on captions by selecting Live Transcript, the button with 2 C's at the bottom of your screen. We are conducting an evaluation of our dementia education sessions as part of this project. You should have received an email with a link to the pre-session evaluation questionnaire, which also contains further information about the evaluation. If you did not have a chance to complete the pre-session questionnaire, we ask you please complete this now using the link provided in the chat. By doing so, you are helping others in your community. Your responses and feedback will be used to show the impact of programs like these to improve the tools and resources provided to individuals living with dementia and the people who support them. I now have the pleasure of introducing our keynote presenter for today's presentation, Elizabeth Kinsey. Elizabeth is a licensed, board-certified speech-language pathologist and the program coordinator for the Ohio Council for Cognitive Health. She holds a Master of Arts in Speech-Language Pathology from the University of Akron. For the past 9 years, Elizabeth has provided education and support to individuals living with a diagnosis of dementia, care partners, and professional caregivers through direct clinical care, education, and community partnerships. Prior to joining the Ohio Council for Cognitive Health, Elizabeth provided speech therapy services to individuals in a variety of settings, including assisted living, skilled nursing, and long-term care facilities, hospitals, schools, centers for developmental disabilities, and rehabilitation settings. Please join me in welcoming Elizabeth.
Thank you so much, Krista, for that introduction. I'm really excited to share this information with you all today. It's something I'm very passionate about, and I'm hopeful you'll learn something new and or take away pieces of information to help you when it comes to mealtime and individuals with dementia and IDD. I would like to add a disclaimer that the information and strategies provided in this presentation are merely information and not advice. Please consult a doctor or other appropriate medical professional for medical advice pertaining to your situation. So with that, here are the objectives for today. Won't read all of these to you, but I do want to address some of the terms I'll be using throughout the presentation. The information discussed today applies to all individuals with dementia, including those with dementia and intellectual and developmental disabilities together, in which I will call IDD. As Krista mentioned, I'm a speech-language pathologist, which is abbreviated to SLP. So with that, let's go over what an SLP is. We work to prevent, assess, diagnose, and treat all different types of speech language, social communication, cognitive communication, and swallowing disorders, including voice disorders. We work across the lifespan, so children to adults. We work in a variety of settings, the ones Krista mentioned with my introduction, in addition to schools, hospitals, home health, private practice. For the sake of today's presentation, I will mainly talk about scenarios and examples centered around individuals living or temporarily residing in healthcare settings, such as those nursing homes, assisted living, hospitals, group home settings. That's a bulk of where my experience comes from, but please know that this is applicable to those living at home or in other settings not mentioned. We collaborate with a wide range of caregivers, professionals in the medical and non-medical field. You can see those listed here. So I'd like to briefly address the definitions of dementia and some common signs and symptoms before we address mealtime specifically. It's really important to understand what dementia is and what it is not, and how to recognize the changes that might point to dementia. It's not a specific disease. It's an overall umbrella term that describes many symptoms related to cognitive changes that affect someone's ability to perform everyday activities. Alzheimer's disease is probably the most common type. It accounts for about 60 to 80%. That's why we hear about it the most often. But there are other types of dementia, including dementia with Lewy bodies, frontotemporal, vascular dementia, etc. Here are the top signs and symptoms of dementia. Again, for the sake of time, I'm not going to go over these in depth, but I do want you to know that dementia is more than just memory loss. And this really applies to today's discussion around mealtime. We make many decisions around our meals and eating that include preparing meals, sequencing tasks. We communicate our wants and needs. Socialization accompanies mealtime as well. So it's not just about forgetting how to eat or forgetting what we ate. So in addition to those signs and symptoms of dementia, I do want to briefly show that there are differences in these signs and symptoms for individuals with IDD. For example, short-term memory loss is usually not an early sign in individuals with IDD. Instead, we look for changes in those day-to-day functions. So for mealtime, this can show up as you might observe changes in the way that they feed themselves, the way that they may need increased assistance to pick up food items, take a drink, etc. They may show reduced enthusiasm for daily activities, so that can be shown in reduced interest for meals and eating in general. There can be a loss of interest in social interactions, so withdrawing from socializing during meals or avoiding social events that include eating or drinking. And lastly, changes in personality and behavior. So there may be changes in their preferences of food and liquids that they typically like, and they may start to resist typically liked items. Additionally, there are specific things to look for in individuals with IDD if dementia is suspected. So there can be newer increased seizure activity, incontinence, mobility changes, and of course, swallowing difficulties. So this is important because a swallowing disorder or mealtime difficulty may already be present in the IDD population. So with dementia signs and symptoms on top of that, it can provide an extra challenge in navigating mealtimes. So you'll see the box on the left, estimates of the prevalence of swallowing disorders in individuals with developmental disabilities suggest that 80 to 90% of the population will have dysphagia or a swallowing disorder during their lifetime. Now, I will say there is limited research in the area of swallowing disorders for individuals with IDD and dementia, but we do know, again, that prevalence number I just told you about there. Additionally, most adults with IDD will live in community settings, either independently or with support from families, friends, service providers, which means they may be at higher need for help during mealtimes or help facilitating mealtimes. So again, I'll be talking about individuals with dementia as a whole, including those with IDD, but I just wanted to illustrate some of the differences that we see with the IDD population. So with that said, let's just jump into the mealtime experience. So just think about the meals that we have. What all goes into it? Well, it's a lot. So first we decide that we even want to eat. Then we decide what we eat, when we eat, how we eat, where we eat, and who we eat with, etc. The list goes on and on. You can see from these photos here, there's a lot of different types of meals, snacks, beverages, holiday celebrations that we have. So as you can imagine, dementia can change the individual's ability to make all these decisions around mealtime and can change the experience as they may begin to rely on others for more assistance with eating or preparing to eat. So as the care partner, we're placed in a position to help the individual maintain their preferences, maintain dignity, and enjoy the social aspect of mealtime, no matter how the disease progresses. So what exactly can happen at mealtime for individuals with dementia? A lot can happen. And again, I'm sure that I'm missing some in these next two slides, but these are just some of the most common things we see. It's a wide range of things that can happen. You might notice just a couple of these things. You may notice many of them. So we're going to go through those now. So first, you might notice just a general disinterest in eating. Since we know that dementia is more than memory loss, there can be a variety of things contributing to what might look like decreased motivation to eat or disinterest in eating or drinking anything. Reasons for this could be that they might not recognize familiar foods. They don't recognize the routine of eating. They may have difficulty recognizing what to do with food and drinks when it's presented in front of them. Especially if they're in a different or a new environment, such as being admitted to a new facility. Mealtime might look a lot different than it did at home or where they were previously. So you may see that disinterest in eating or drinking. Trouble using cups and utensils. Individuals with dementia may have difficulty recognizing items and their functions. So for example, I might see a fork, but I think it's a hair comb. So I'm not going to use it to eat because I think it goes in my hair. Slow and reduced movements. Individuals with dementia may take a longer time to eat, may take a longer time to process and sequence the events of eating. So they can also have physical limitations that can make eating just a longer process. So this can result in an increased need for assistance from the caregiver. Confusion with time or place. So individuals with dementia may feel that it's morning, it's time for breakfast, they're waiting on their cup of coffee when actually it's supper time and they're being served spaghetti. They may, again, confuse where they're at. So especially if they're in that new environment, they may not quite recognize what the mealtime process looks like in that new environment. Visual spatial difficulties. So visual spatial is the visual perception of spatial relationships and objects. So looking down at the meal and seeing kind of where everything is. Individuals may mistake non-food items for food. They may be unable to locate food items on their plate. There might be poor contrast of the food item in the plate. They may reach for a salt packet thinking it's a sugar packet and they're putting it in their coffee and then they're realizing their coffee doesn't taste very good. Individuals with dementia may have difficulty communicating. This is no different at mealtime. They may have trouble verbalizing their wants and their needs. And this is huge for mealtime. You know, what do you want to eat? What do you like? What don't you like? Why aren't you eating? Is the food too hot? Is it too cold? Does it taste bad? Does it need salt, pepper, etc.? Individuals with dementia may have trouble communicating in that they may have undetected pain or something that's bothering them and they can't really communicate with you what that is. And you'll see that in mealtime, especially if there's pain localized to the mouth or head or neck area or teeth, making chewing or swallowing painful. And lastly, there can be a change in taste and smell. So overall reduced sensations related to how food tastes and smells. So food just might not taste good. So think of like when you're sick, you lose some of that taste or the ability to smell. You're like, oh, nothing really sounds good right now. So kind of a similar thing there. More on mealtime and dementia, effects of medication. This is huge. Individuals with dementia may take multiple medications. So are these medications having a negative impact on their alertness at mealtime? Are they causing them to be nauseous, or is it causing a decrease or even an increase in their appetites? We want to look at what medications they're on, when they're taking them, and how that might be interacting with mealtime. Decreased socialization. We know that eating is a hugely social part of our lives. As you may see in individuals with dementia, they might start to withdraw from social activities that are built around eating. So think of especially summertime's approaching, backyard barbecues, birthday celebrations, ice cream socials, happy hours, etc. For individuals in facilities, they may used to eat with a certain group of individuals. You may see them now start to say, well, I'd rather eat in my room. And it could be embarrassment with their communication and their interactions, embarrassment or shame with not quite understanding what mealtime, how to navigate mealtime at that point. And as a result, mealtimes can be negatively impacted. There can be a change in physical activity. So appetites may change due to how much the individual is moving. So if they're moving more, they might be hungrier. If they're moving less, they might not need to eat as much. So kind of watch for those things. Changes in muscles and nerves. So there are over 30 muscles and nerves involved with chewing and swallowing. So there is a normal aging process of the muscles and structures needed for chewing and swallowing. So think of like reduced muscles and movements in your body as we age. Same goes for those muscles used for swallowing. This might make chewing foods more difficult, and if there's a reduced ability to communicate, they might not be able to access softer foods if they can't ask for them. And that might be something that would be helpful for that individual. Decreased judgment. An example at mealtime would be taking too large of bites, eating non-food items, taking a bite of something that's too hot, improper posture and positioning, maybe trying to eat or drink while laying down in bed, using utensils improperly, etc. There can also be a change in intake amount. So this is very common in individuals with dementia. A lot of times there's a concern for weight loss, and it's really hard as a caregiver as you want the individual to maintain a healthy weight. So especially as the disease progresses, this might put them at risk for malnutrition and dehydration. On the flip side, we may also see an increase in intake. So if the individual has trouble keeping track of when they last ate, they might be eating a lot more than they need, and they may be at risk for gaining an unhealthy amount of weight. So something to look for there. And lastly, there could be a unrecognized swallowing disorder, and I'm going to talk about the signs and symptoms of swallowing disorders later. But if this goes unrecognized, this can really put the individual with dementia at risk for a variety of things to happen with their health, and especially at mealtime. An example of something that might happen that would be a sign or a symptom of a swallowing disorder would be pocketing or holding food. So that means when the individual might chew and chew and chew, and then they get food, just kind of think of chipmunk cheeks. There's just food sitting and they won't swallow. So recognizing that that might be going on, and you can have an SLP do a full assessment to kind of see what's going on and see if there are things that can help the individual. So it's important to know those signs and symptoms. And again, we'll talk about those in a little bit. So knowing that there are many ways mealtime can be affected by dementia symptoms, let's dig a little deeper into what we can do as the care partner. These whole, I think, next 3 slides are very much a guess and check, trial and error, as I'll call it. So a lot of this is getting to know the individual with dementia. And as we know from working with individuals with dementia, this can change a lot. This can change day to day, meal to meal, month to month. And not all of these will apply to everyone with dementia. So again, trial and error, but sometimes the easiest strategy is right in front of us. So starting with these basics can really help set the individual up for success. So believe it or not, this actually begins before the meal. Do they have what they need to communicate? Do they have the tools to meet their basic needs? First one on the list is dentures. After working in many facilities, dentures get lost a lot. If you guys have kids also with retainers, you know how often those get lost. They're really hard to keep track of. So if they have dentures, do we know where they are? If they do they have a top and a bottom, or is it just a partial? How are they staying in place? Do they need an adhesive to stay in place? There are different types of adhesives that can help dentures stay in place. Individuals who have had dentures for years may have had some bone loss just over the years, and it can really impact the fit of dentures. So seeing a dental professional frequently to make sure that they're fitting right is really important. As dentures that are loose fitting, they may move around a lot in someone's mouth and may prevent them from chewing properly and can actually put them at risk for choking. So dentures are really important. To piggyback off that, oral care is really important. It may impact the individual's desire to eat if their mouth just doesn't feel good, if it doesn't feel clean. So we want to make sure we're brushing in between meals or maybe doing a mouthwash. A lot of times we see thrush on the tongue, which is just a bacteria overgrowth that might be a sign they may need better oral care, or it might be because of some medications that they're on. So I know that oral care can be really challenging for individuals with dementia. I mean, trying to brush somebody else's teeth in general is challenging. So it's a whole separate discussion, but I will say collaborating with those dental professionals and SLPs can kind of help navigate the difficulties of that. Poor oral health is one of the leading risk factors for something called aspiration pneumonia. And I'll talk about that in a little bit. So we want to make sure that oral care is being done and being done the right way. Do they have hearing aids? So are they in and working? Do they need new batteries? You know, we want to make sure that they can, first of all, hear you when you're asking them what they would like for lunch. Communication devices. So some individuals with IDD or dementia as well may have a communication aid or communication device that they need to communicate. This is huge in identifying their preferences and also to assist them with socializing during meal times. So we want to make sure that they have those devices handy at mealtime and it's not, you know, in a drawer somewhere. Do they have glasses or contacts? So we talked about some of those visual spatial things that can happen. So aside from that, can they see what's in front of them? Do they have glasses or contacts that may help them see what they're eating? Brings me to positioning. So we want to make sure that the individual's in a well-supported, comfortable chair. We want to make sure that the table position is close enough to them. It's not too high, it's not too low. A lot of times in facilities, they have those tables that can move up and down. So we want to make sure that it's at the right level for them to reach everything on their tray. Upright posture is really important. We try and suggest that people stick to a 90-90-90 rule, which means elbows bent at 90 degrees, knees at a 90-degree angle, with feet flat on the floor and hips at 90 degrees. Now, if you know somebody with dementia or someone with IDD, think of how they might achieve that position. It's probably really difficult. So if it's not feasible, we want to just make sure that they're as close to that as possible with being comfortable. You're not going to want to eat if you're uncomfortable. Lastly, wheelchair considerations. After working with a lot of physical therapists, I have learned that there are many types of wheelchairs with many functions for many different reasons. So again, do they need a pillow behind their back? Do they have footrests that they can keep their feet firm on to help stabilize their core while they're eating? Environment is huge. We want to check the environment, make sure that there's not too much background noise, that the lighting is adequate. So if it's too dark or too bright, we want to make sure we're looking at that. Table location. And again, this really depends on the individual, but do they want to be at a table with other individuals? Do they want to be at a table that's maybe facing a window with a look of a beautiful courtyard? So we want to also consider if there is a window on the other side of them, is there a glare coming in, bouncing off the fork into their eye, and then now they really can't see what they're doing. So consider the table location, also consider the table content. So think of the centerpieces that are on tables. If there's just random pieces of paper on the table. I worked in a facility and there was a individual with dementia who they would sometimes not catch it, but they would leave little straw wrappers or napkins and she would just try and grab all of them and start trying to eat them because, you know, she thought she's sitting down for mealtime, here's my food. So we want to remove as much unnecessary clutter from the table as possible. We also want to consider room temperature. So again, you're not going to want to eat if you're uncomfortable. So checking the individual to see if they might need a sweater, if it's really cold in the dining room, or if it's too hot, addressing their clothing for that. Socialization, who else is at the table or who's nearby when eating? Do they like to sit with a group of people, like I mentioned before? Do they prefer to sit by themselves? If they are eating with other individuals, they might not know. Do they have good feelings around them, or is it somebody that they argue with or don't have good feelings with? So we want to just make sure that the people around them while they're eating are pointing to a good mealtime experience. We want to consider a consistent routine for individuals with dementia. So for example, if they're in a facility, Maybe one of the nurse's aides comes and gets them at a certain time every day, and they go down to the dining room together and have a nice conversation. Or if they're at home, maybe there's a certain show on. For example, I think Price is Right is still on at 11 o'clock. So maybe if it's on for a half an hour, when it's over, they know right at 11:30, that's my cue. Price is Right is over, it's time to go eat lunch. Another example, some individuals want their bowl of ice cream before they go to bed at night. I have my dinner, I have my dessert, now I'm ready for bed. So just consider those consistencies and routines that might kind of cue for what's about to happen next. I also want to add to keep in mind prayer rituals or other religious activities associated with the individual's eating preferences that may help with those routines associated around mealtime. Trying to identify food preferences, I could probably go on and on about this one. This is a lot easier said than done. Like I said, this can change from meal to meal, day to day. You thought somebody liked pizza and yesterday they did and today they didn't. So I want to emphasize that we really have to get to know the individual with dementia, talking to multiple caregivers, family members, seeing what worked when. Maybe something worked really well at breakfast, it doesn't work so well at supper time. So just things to consider when trying to identify food preferences. Try and make notes and observations, write it down so you can refer to it later. Try and look for themes or things that you see that might be consistent. So example would be if they really like tomatoes, you're noticing they like strawberries, carrots. Maybe those colors are really appealing to them instead of those beige colored foods like pasta, bread, and potatoes. So maybe they're refusing chicken breast and steak and pork chops, but they're really enjoying hamburgers and casseroles and ham sandwiches. So that might be that meat is too tough to chew for them and they just don't want to bother with it. So then you try and serve ground meats with gravy, thin lunch meats, or casseroles as softer options. So try and look for those themes. Those are just a couple examples. Also, showing pictures of food items may help in determining those food preferences if communication is a challenge. We want to evaluate eating times and types of meals and snacks. So how often do they prefer to eat? Sometimes eating breakfast at 9 a.m. and then lunch at 11 is just too close of a gap and they're just not hungry. Do they like 3 large meals a day with a couple snacks in between, or do they just want to snack all day? So kind of trying to identify what works for the individual. We want to explore equipment and utensil options. So everyday utensils and cups may become challenging for individuals with dementia due to physical, visual, and perceptual changes. So consider a consult with an occupational therapist and or an SLP in these situations to identify equipment that might make mealtime easier. We also want to consider food presentation and those visual considerations. So keep it simple. Too much food on one plate can be really overwhelming. Try smaller portion sizes if you notice they're overwhelmed. Try serving things separately one at a time. Try vibrantly colored bowls and dishes, or maybe a brighter tablecloth to increase that contrast. So I included some pictures here just to kind of show you what I'm talking about. The picture on the left is a pretty typical nursing home or other facility presentation of a meal. So you can see that there are about 7 different items presented at one time. So this can be really overwhelming for individuals with dementia. This can be overwhelming for individuals who do not have dementia. So it's like, where do I even start here? So individuals who have those visual spatial difficulties, difficulty sequencing, problem solving, it's a lot to navigate and process this. So in this situation, I would maybe just take one item off that tray at a time, put the tray to the side and say, let's start with a salad, or let's start with soup and salad, kind of see how that goes. The picture on the right is just another option. Again, I mean, these might not be things you would serve. It looks like fruit and ice cream and pudding or something, but the vibrantly colored small bowls, maybe present them like this or one at a time to help with decreasing that feelings of being overwhelmed. Especially with the meal on the left. One complaint I would hear all the time in facilities is everything is cold, or now this is cold, can you go heat it up? So, you're not going to want to eat your spaghetti or drink your coffee if it's cold. So just something to consider with presenting all of that at one time. I also wanted to provide a couple examples of the equipment and utensil options you might see suggested by an SLP or an occupational therapist. The top two, you can see there are different cups. These help individuals move the cup properly. Other ones help regulate the flow of how the liquid flows. So this might be helpful for individuals who have a swallowing disorder. Again, these are just a couple examples. There are a lot more. That divided plate, that red plate at the bottom, helps the individual see where each food item is, and it's brightly colored, so increases the contrast. And then there's these two options of utensils that make it easier for the individual to hold. So I want to just provide you with a couple general mealtime tips. Try having readily available snacks and drinks on hand. You can see this picture here is an example of a snack cart that can be left out. You can do this at home. You can do this in a facility for the individual to just kind of walk by, grab what they want. This can help increase the nutrition and hydration of our individuals with dementia. Additionally, individuals with dementia may want to walk around and they don't want to sit down for 3 meals a day. So in those situations, we really want to try and meet them where they're at. So if they're walking up and down the hall, you might grab an apple or a snack like a granola bar and say, hey, I have this extra apple, do you want it? Or here's an extra granola bar, you can take this for later. And that allows them to eat it when they want to. Think of adding sweeteners, seasonings, sauces, etc., as their dietary restrictions allow to increase sensations and flavors of food items. Finger foods is sometimes a helpful consideration for individuals with dementia. These would be things like sandwiches, chicken nuggets, raw fruits and vegetables, pizza, grilled cheese, just things you can hold with your hand. Switching up the environment, again, trial and error. This might not work for everybody with dementia. If a change in the routine is not disruptive to them, try eating outside if it's really nice. This might increase positive feelings associated with mealtime, enjoying the outdoors and a nice meal at the same time. You can try what I call restaurant style. So act like you're ordering at a restaurant. You're going to play the server, sit the individual with dementia down, maybe provide them with a menu that has pictures of food items you have, pretend like you're taking their order, serve the meal to them, and then maybe if they ask for the bill at the end, say it's on me today. So some individuals benefit from that type of mealtime setup, especially if they like to go out to eat. My last tip here is to avoid offering high-calorie drinks like Ensure or Boost before a meal is given. Now, a lot of individuals benefit from these supplements, and that's great. I've seen sometimes if they're served too close to when the actual meal is being served, then they don't really want to eat the meal because they're full from the drink. So just think of when you're serving those nutritional drinks. All right, so that brings me to mealtime communication. As many of us know, communication is so important for interacting with individuals with dementia. We want to assess the communication. Again, this is before the meal even happens. Was there a stressful event right before mealtime? Or maybe they had a really busy morning of running errands and they're just exhausted and, a meal just doesn't really sound good right now. So we want to make sure we're addressing whatever, if there's a negative communication exchange right before the meal, to consider how that might affect their mealtime. Using positive facial expressions, a smile goes a really long way for individuals with dementia. We want to create a positive experience with mealtime always. We want to offer patience and support. So oftentimes individuals with dementia may take a while to eat, and that's okay. Rushing them can cause agitation or a decrease in eating. Also be aware that if they're taking an abnormally long time to eat, it could point to a swallowing disorder if they're chewing too long or having difficulty swallowing. On the other hand of that, eating at a really fast rate can also contribute to difficulty swallowing and can increase choking risk, which we'll talk about a little bit later. Offer comfort and reassurance. Sometimes individuals with dementia may look reluctant to try something. They might not know what it is. So I'm not really going to jump right into that pile of whatever it is if I don't know what it is. So provide comfort and reassurance by saying, you're doing a great job. That coffee smells amazing, or I love that salad too. I want to add there can be visual deficits and hallucinations sometimes for individuals with dementia. They might see something in their meal that's not there. So an example would be seeing bugs in their food. You as the caregiver, go over to them and say, you know what, I'll take that plate away for you. I'll bring you a fresh one, give them a snack in the mealtime. So you're acknowledging what they're seeing is very real. You're going to do something about it, and you're going to provide them with a new meal. We want to avoid criticizing, correcting, and arguing. If they call their piece of chicken a pork chop, don't argue or correct them, just let it go. If they only want to eat the sweet items on their plate, provide a little positive encouragement to try something else. And if they don't, just let it go. Don't argue, just provide them with what they're asking for also. Using short, simple instructions and yes and no questions can help determine those preferences. Using direct language like it's time for breakfast or here is your cup can be helpful instead of asking open-ended questions. Additionally, the use of yes or no questions can be helpful to identify preferences by saying, do you want soup or salad instead of what do you want for lunch? It's a pretty broad question. We want to use positive language around mealtime. This is huge. If you tell someone who's unsure of what they're eating that you don't like it and you think it's gross, do you think that they're going to want to try it? Probably not. So using positive language around the food they're eating can really help make it more appealing. Say something like, yum, I had those potatoes for lunch too, or that omelet looks delicious. How does it taste? We'll talk about this in a little bit too, but some individuals may be on a modified diet due to a swallowing disorder. So if you say, ooh, I really wouldn't want to eat that either, that's disgusting, and then provide them with nothing else, they're not going to want to eat it. We want to decrease distractions at the meal. So are you sitting with them or are you busy doing something else in the other room? Giving that person an environment that's free of distractions is really important. Lastly, individuals with dementia may need frequent reminders throughout the meal, such as slow down or take a drink. If they're eating too fast, they may have trouble following these commands. So it may be helpful to create signs or to label things to help with the comprehension of what you're trying to say. So that brings me to tips to encourage dignified dining. So dignified dining is a very important aspect of our day in life. When we're having a meal or a snack, we're most likely in the presence of other people. So we want to make sure we're maintaining an environment that's clean, tidy, eating and drinking where the person is comfortable, wearing clothes that makes us feel good, etc. So here are some tips for that. Number one, listen to the individual. This goes hand in hand with communication, but if they're saying, I'm not hungry or I don't want that, don't argue or force the issue. We can't force others to eat. We can set them up with good opportunities and positive experiences, but sometimes we have to just try again later or try a different approach. Clothing protectors, some individuals wearing clothing protectors as an adult, which some facilities call them bibs. So as you can imagine, that could decrease dignity as an adult wearing something that's made for a child. On the other hand, not wearing one and getting spaghetti or whatever it is all over your shirt and then having no one change your shirt and you're wearing that the rest of the day can also decrease dignity. So again, talk with family, talk with the individual and other caregivers about their preferences. We want to facilitate a natural and familiar eating environment the best that we can. So again, joining them for mealtime, engaging in a nice conversation with them can be a natural and familiar environment. Allow them time to enjoy the meal. Like I said, individuals with dementia might take a little while to eat. Try not to rush them. We want to empower them to make choices. So take a seat in the chair of the person with dementia and consider what it would be like to lose the ability to decide what you want to eat. Empowering the person to choose what foods and drinks they want to enjoy can allow for a more positive mealtime experience. Also tell them what they're eating. Like I said, individuals with dementia might not recognize what they're eating. So name what each item is, either right before they eat it, or if you put the plate or bowl down in front of them, tell them what it is. Check the food and liquid temperatures of the meal, like that tray I showed you a couple slides back. If you're provided the individual with dementia all that food at one time, there's a good chance it's going to get cold. So I wouldn't want to eat cold spaghetti myself. I wouldn't want to eat vegetables if they're cold. I might not be able to ask you to reheat them. So as the caregiver, I want to make sure that food items are at the appropriate temperatures or what the individual likes. Again, touched on this already, eliminating distractions and being attentive to the individual, try not to sit on your phone while you're with them, make eye contact, engage in that conversation. Allow independence and give support. So let them try and show you what they can do before just jumping right in. And know that the need for assistance can change. So if they're having trouble getting started, offer to open up food containers, set up their utensils, cut things for them, put their cream and sugar in their coffee. Sometimes individuals might need utensils loaded with food. So you're taking your fork or spoon, putting the food on it, handing it to them, and then they're doing the rest. So just kind of figuring out what that individual needs is a little bit of a guess and check as well. Don't force feed. This seems kind of crazy to say this, but as dementia progresses, a lot of times as a caregiver, we want the individual to eat more and eat more. We're worried that they're going to be losing weight. And that's a very valid concern. But the first phase of swallowing is voluntary. So that means that I have to want to eat myself. We all have to decide that we want to eat. Nobody else can decide that for us. So if they do not open their mouth voluntarily, they are not ready to accept food, and doing that can put them at risk for choking. And then assist with cleanup as needed. So of course, you would wash their hands before eating, as we all do, but if the individual needs assistance in washing their hands after the meal, if it's been a messy meal, wiping their mouth, making sure they're not walking around the rest of the day with food all over their mouth or their shirt. All right, so now we're going to jump into swallowing disorders. This is what's called dysphagia. So just some stats here. Swallowing problems occur in about 45% of those who have been diagnosed with Alzheimer's and other dementias, and the number increases as the disease progresses. So some degree of a swallowing disorder is found in close to 80% of individuals with dementia living in care communities. So those numbers are pretty high, which is why it's important to understand. So difficulty swallowing or eating is called dysphagia. It can happen in one or more of these phases of swallowing. Won't get into these in depth here, but there's an oral phase. So that's anything here, your lips, your teeth, your tongue, your mouth. Pharyngeal phase would be anything on the inside in your throat area. And then esophageal phase is the tube that connects your throat to your stomach. So there can be issues in any one of those areas. It's diagnosed and treated by an SLP. And here are the other disciplines that might play a role. Here are some causes of swallowing disorders: any change to the brain, strokes, you can see Alzheimer's disease and other dementias, and some of the developmental disabilities listed here. Additionally, there can be head, neck, or mouth issues. So again, think of if an individual with dementia has, in addition to their dementia diagnosis, cancer or a head or neck injury, mouth or neck surgery, etc., can provide an extra challenge. Here are the signs and symptoms of a swallowing disorder. Again, if you suspect or witness any of these, it's best to discuss it with your physician, with the individual's physician, so that they can get you a referral to see an SLP for further evaluation. The SLP may see them at a bedside exam, or they may suggest additional testing. There's a variety of tests that we can do to figure out what's going on. But if you see any of these things, coughing during or right after eating or drinking, clearing their throat often after eating or drinking, having a wet or gurgly voice just during or after eating or drinking, feeling like something's stuck in our throat or chest, needing extra time or work to chew or swallow, having food or liquid come out of our mouth while we're chewing or trying to swallow, having food getting stuck in your mouth, so that's that pocketing I was talking about, and then having a hard time breathing after meals and weight loss. So why are swallowing disorders a problem? They can lead to dehydration and poor nutrition. We have two tubes in our throat. One goes to our lungs, one goes to our stomach. We've all experienced when things go down the wrong pipe. When this happens, we cough, we try and get it out. Food or liquids may enter the lung space and can contribute to the person developing aspiration pneumonia. This can happen with our own saliva even. And the greatest predictor of this type of pneumonia is when the person depends on others for feeding. So that's why this is so important for the dementia population. Swallowing disorder can also contribute to reflux and other gastrointestinal issues and a decrease in function and health over time. So if a swallowing disorder is identified, what do you do? So there are many strategies and interventions out there that can be done by an SLP if dysphagia is identified. I will say in the dementia population, it's really difficult at times to do specific strategies, and we rely more on the caregiver to implement those. So that's why it can be difficult in facilities or for those individuals who don't have care partners. So exercises and treatment plans can be developed to help the individual use their muscles to chew and swallow. There can be instruction on ways to sit or hold your head while eating, strategies for safe swallowing, diet modifications. This would be eating softer foods or drinking thicker liquids to help make swallowing easier and safer. There's something called vital stim where they hook electrodes up to your throat to help get things kind of moving the way that they should. And then other means of nutrition, that would be your feeding tubes. All right, I also wanted to add this in here. We see concerns for choking often in the dementia population. And a lot of what's listed here is they are things that individuals with dementia are susceptible to because they rely on others for assistance with meals. Additionally, a lot of what we talked about in the beginning of the presentation, so think back to the basics, the environment, and communication tips is applicable here. So you'll see distractions while eating, swallowing non-food items, poorly fitting dentures, staff and caregivers not familiar with their preferences and their level of assistance, poor positioning, etc. Individuals with dementia may have difficulty responding to cues, like slowing down if eating and drinking too fast. So that's why that supervision is so important. So I also wanted to add, I put these pictures here of popcorn and hot dogs that commonly choked on foods are the two of those, in addition to grapes, steak, things that are mixed consistencies. So that means cereal, fruit cups, and syrup, or like a vegetable soup. So you have like the cereal, you have like the hard part that you would chew, and then you have the milk, which is a liquid you have to swallow. So you're trying to manage two different consistencies at one time. So just wanted to leave you with those here. And then lastly, I wanted to leave you with some general safe swallowing strategies that may be helpful for individuals with dementia. Again, everyone is different. So keep in mind, individuals with dementia may need a lot of verbal, visual, and even tactile cues to do these things throughout the meal. We want to make sure we're maintaining an upright position when eating or drinking. We're taking small bites. We're taking a small bite and then a small sip of liquid, kind of alternating to help wash things down. We want to alternate temperatures and taste to increase sensations if we can. So taking a bite of something that's warm and then something that's cold right after to increase those sensations. We want to encourage eating at a slower pace, avoid talking while chewing, checking for the pocketed food in the cheeks, and then sitting upright for at least 30 to 45 minutes after meals, so not immediately going to lie down. So lastly, I just want to leave you with, we really owe it to the individual with dementia to support them during mealtime so we can help maintain their preferences, dignity, and to enhance their lives with the joy that comes from eating and drinking. So with that, I have resources and references here, and I will turn it back over to you, Krista.
Thank you, Elizabeth. We have time for a few questions from the audience. Please remember to submit your questions using the questions box in the control panel on the right-hand side of your screen. Our first question is, when a loved one loses interest in eating, what can you do to make them more enthusiastic?
So a lot of what I talked about earlier, again, it's that trial and error. So kind of try and identify what did their meal times used to look like, maybe before you noticed dementia. You may try and replicate some of those mealtime scenarios, or it may be something completely different. Maybe they used to really like those 3 big meals a day, but now they benefit from going out to eat, getting a snack here or there. So just kind of doing a little guess and check on your end of what things used to look like, what they're looking like now. And again, using that positive language, positivity around mealtime. It's not just sitting down because we have to eat because we need to stay at a certain weight and we need to stay hydrated. It's let's make it fun. Let's cook a meal together or create a snack together. Those would just be a couple of my suggestions.
Wonderful. There is also a request in the chat to put those resources back up on the screen if that's possible.
Yes, sorry.
And just so the audience knows, I see a couple different questions in the chat. We will be emailing out the PDF of the slides as well as a recording of the presentation following today's presentation. And we're excited that so many of you are interested in this information. So thank you for all of that positive feedback. Our next question, it's more of a comment, is that finger foods can be a generational thing. This audience member experienced elders wanting meat and potatoes as a meal for dinner or supper, feeling like sandwiches are more of a lunchtime thing. What advice do you have for identifying foods that work best for individuals at different times?
That's a great thought. Again, it's just that trial and error. You're going to just have to try different things at different times. Especially, I would like to really focus on like what is working instead of what's not working, to really implement those things at, maybe I really like breakfast. I would be okay with eating breakfast at supper time. So trying to figure out creatively, I guess, how can this might not look like a traditional mealtime like it used to. And again, things can really change day to day, meal to meal.
Wonderful, thank you. Our next question is, it's also a little bit of a comment. This attendee wanted to stress the importance of cleaning people's dentures after eating so that they don't aspirate on food that might be in their denture plates. Are there what other risks come to your mind for aspirating food?
There's a lot, and it depends what else the individual has going on medically. But starting with those basics and those really easy things, unfortunately, I mean, you would be surprised as to how dentures are not cleaned in between meals. Also, having individuals sleep with them in their mouths if they're not secure can put them at risk for choking. So, and again, I want to add to, if we have individuals who are familiar with the medical setting on the call, that just because somebody aspirates does not mean that they're doomed. Depends on how the individual can react to the aspiration. So if they can clear the food, if they don't have anything else going on contributing to the weak muscles, etc. So that's a whole other presentation I would love to dive into, but I'm hoping that some of these resources here can help provide a little more information if you're wanting to know more about swallowing disorders and aspiration.
Thank you. What are your thoughts on someone chewing their food and spitting it out? Does that sound like a swallowing disorder, or what things should you consider if that's what a resident might be doing?
I would definitely get an SLP involved, but I would also consider, again, kind of making that list of, is this happening with all food items, or is it certain textures? Is it certain tastes that they're doing this with? Is it certain times of day? So really kind of playing detective and figuring out when it is going on. In those situations too, sometimes like those modified diets I talked about, I didn't really go in depth with them, but sometimes things are just harder to chew and you might see a benefit from providing that individual with softer food items. So again, guess and check. I would get an SLP involved to kind of do a full assessment and see if there's anything else going on. It could be the reduced sensations with a dementia diagnosis, or there could be something more pointing to a swallowing disorder.
Thank you. And we have time for one last question. How do you advocate to make sure individuals are not segregated or excluded from communal dining experiences because they cough or hack?
Ooh, that's a good one. Mealtime is everyone's right to have what they want and have what they need. I know sometimes in facilities that can be tough with staffing and patients needing a certain level of assistance. I would really, refer to this presentation and the resources here that mealtime is an experience. Talking with family members or caregivers about what would be important to that person at mealtime. Just because somebody has signs or symptoms of a swallowing disorder doesn't mean they don't have a right to a dignified dining experience as well. So that's a really tough one.
Wonderful. Thank you so much for all of your answers. I know there are a couple questions we didn't get to. Thank you to our audience for your participation. Before we conclude today's webinar, Project Director Bronca, Elizabeth, could you unshare your slides, please?
Yep.
Thank you. Before we conclude today's webinar, Project Director Branca Promedica is going to tell you briefly about BRI Care Consultation, a care coaching program available for families impacted by dementia in various counties in Ohio through the Administration for Community Living project. Branca?
Good afternoon, everybody. And again, thank you, Elizabeth, for the very enlightening presentation. I was following the chat messages, and it seems that there are a lot of really great takeaways, and the attendees are really able to apply their current work to, the material that was presented. So thank you very much. I just want to share with you a little bit about BRI Care Consultation. As a part of this ACL project, we are offering the service for free of at no cost because it's generally funded by the Administration on Community Living. So this is a telephone and email-based care coaching program, and it assists persons with or at risk for dementia, including IDD, and really provides support to caregivers or other supporters. Next slide, please. So I'll tell you a little bit about what a care consultant does. So a care consultant, I'll show you the contact information a little bit, but when your client's connected to the care consultant, basically it is one care consultant that helps with finding and getting connected to health and community services. So really identifying what the needs are and helping navigate the services, and building this action checklist. Is basically a step-by-step plan where the plan guides individuals based on needs, helps with bridging communication between family and friends, and helping to guide and really provide information on how to manage difficult situations and behaviors. And I saw that many of our care consultants have attended this training today. So a lot of this information will be applied to discussions that are taking place with clients. This is an ongoing program, so it's not just a one-time phone call. The care consultant continues to stay in touch with individuals and families. And it also serves as an emotional support when overwhelmed or faced with challenges. Next slide, please. So the way that you would get connected to BRI Care Consultation is you can see here that the project covers a variety of counties in Ohio. So we have Cuyahoga, Lake, Geauga, Lorain, and Medina counties. Welcome House is the organization that serves individuals with IDD and their family, friends, other supporters. So you have that contact information there. We also have the Benjamin Rose Institute on Aging that provides a service under the name of We Care Because You Do. And you have that number. This is for individuals without intellectual or developmental disabilities. So that's the organization that you'd want to contact. We also have our southeastern counties, including a couple counties in West Virginia, served by O'Neill Center. And then, of course, United Seniors of Athens County, serving Athens County, Ohio. Now, if you're the caregiver or the individual with or at risk for dementia does not reside in any of these counties, please give Benjamin Rose Institute on Aging a call, and we can help direct you to a local organization that does provide the service, or we could talk about other options as well. So there is the outline, and as Krista had stated, these copies of the PowerPoints will be emailed to you and provided, so you will have that contact information. So thank you very much. Back to you, Krista.
We want to thank you again for joining us for making the most of mealtime, eating, swallowing, and dignified dining for individuals with dementia and IDD. A recording of today's session will be made available at www.benrose.org on the event registration page and in our resource library. To stay up to date on dates and topics for more upcoming webinars, please visit our website. In the chat, you will see a link to a post-session questionnaire. You will also be receiving it via email later today. We ask that you please complete this post-session questionnaire within 1 week following today's session. Your responses and feedback will be used to show the impact of programs like these and to improve the tools and resources provided to individuals living with dementia and the people who support them. Thank you again for joining us, and have a great rest of your day.